Hi, my name is Christopher Voscopoulos of Medical Specialist Associates, and this video is on the clinical use of ketamine outside the operating room. For those of us that are critical care anesthesiologists, we have an extensive experience of using ketamine within the operating room and for procedural sedation. However, arguably, ketamine is not used enough outside the operating room, in which there are widespread uses for it. Thanks for watching, and thanks for learning with us.
Medical Specialists Associates, making medical education more accessible.
Hi, my name is Christopher Voscopoulos of Medical Specialist Associates, and this topic is on the clinical applications of ketamine outside the operating room. For those that might want to delve into this topic a little bit deeper after this presentation, here's a great paper titled The Reemergence of Ketamine for Treatment in Critically Ill Patients that you might want to look up. So let's start with some background in pharmacology. So ketamine was first used in the 1960s for surgical interventions at the University of Michigan and received FDA approval in 1970. So it's a short-acting derivative of phencyclidine, otherwise known as PCP, and ketamine is about 1/10 the potency of its parent compound, PCP. So it exhibits dissociative effects by perpetuating a dreamlike detachment from the environment. So this is very interesting. So what we're saying here is that in essence, ketamine disassociates the mind from the body, and for the most part keeps the body functioning intact, meaning that an individual can still move and that an individual can still breathe. Most importantly, they can maintain their airway reflexes while their consciousness is not associated with their body. You can see how this has huge implications outside the operating room, whereas when we talk about procedural sedation, say with maybe propofol, that has real consequences on apnea and even muscle paralysis to a certain degree. You also have some difficulties with Versed or other benzodiazepines as you get into higher concentrations, to where someone could start to lose their airway. So the fact that ketamine will disassociate the mind from the body and leave airway reflexes for the most part intact has tremendous benefits for us in the ICU, and that's why we're excited to talk about this more. So there is current interest in ketamine for its analgesic properties, which we'll talk more about, sedative properties, anti-inflammatory properties, antidepressant effects, as well as, again, those preservation of airway reflexes. So ketamine, for the most part in the US, is going to be a race-mix mixture of both the S and the R enantiomers of the parent compound, and you have primary metabolites of norketamine and hydroxynorketamine, which are still both active compounds, though just with less potency. So the major mechanism of action is through non-competitive inhibition of NMDA receptors, but we will talk about other mechanisms of action as well. So the S enantiomer of ketamine is about twice as potent as the R. Again, this drug is associated with dissociation, and you will have lack of recall, amnesia, and you could also have some catatonia and, again, some muscle movement after you give the drug. So antagonism of the NMDA receptor causes analgesic and antidepressant effects, are influenced mostly by the R enantiomer and by the hydroxynorketamine metabolite. So analgesia may also be mediated through serotonin and norepinephrine reuptake. For those, you might recall that there are descending inhibitory pathways to the brain which act on the spinal cord to prevent some pain reflexes from coming up to the brain. And there could also be, and there is actually, some activation of opioid receptor agonism by ketamine as well, where the S enantiomer is more involved than the R, and norketamine is involved as well. So ketamine can also be used in pain medicine in reference to what is called opioid-induced hyperalgesia and a wind-up phenomenon. And so individuals who are on long-term opioids can develop a tolerance and require higher dosages of opioids to get the same effect. And ketamine can be used to wind down and to reverse that process. Now, ketamine, unfortunately, especially with higher dosages, can be associated with what we would call bad trips or bad hallucinations. Now, to mitigate that, we can give a benzodiazepine. So to be clear, the benzodiazepine does not prevent the individual from having those hallucinations. What it does is it prevents the recall. And also, one of the difficulties with ketamine is that we can get hypersalivation, and it could be really an excess amount of salivation. So though the airway reflexes are for the most part intact, if you're doing, say, something like a bronchoscopy or otherwise, you have this much secretions, it could become difficult. And so pre-medication with benzodiazepines and alpha-2 agonists, which both have anticholinergic effects, specifically the antimuscarinic effect, can mitigate that hypersalivation. So this is something that you want to keep in mind. We would give something like Versed for a benzodiazepine or something like Precedex for the alpha-2 agonist. So just a little more background in pharmacology here. Ketamine binds both nicotinic and muscarinic acetylcholine receptors, and that's why you get that hypersalivation. Blockade of the alpha-7 nicotinic acetylcholine receptor and direct and indirect effects of monoamines, things like dopamine, serotonin, and norepinephrine, are proposed to be involved in its antidepressant effects. And this is a very fascinating area in that, as most might be familiar with, conventional antidepressants can take around 3 weeks or so to kick in, whereas treatment with ketamine is almost instantaneous for the reversal of depression effects. So blockade of catecholamine reuptake can lead to some favorable hemodynamic profiles. However, you have to be careful with this. You can get outright hypertension after using ketamine, and you could get some tachycardia. But again, as compared to something like propofol, in which we can get, very profound hypotension, and that could be something more of a concern in the ICU as compared to the OR, where we might have more control of pressors available to us. Ketamine is very attractive in this regard. And also remember that you don't have to use these agents together. You can combine propofol and ketamine and try to balance out the effect. However, something that might be overlooked is that the catecholamine reuptake is what's called an indirect effect. Ketamine itself has a direct myocardial depressant effect. Why might these be particularly important in this talk and related to the ICU? Well, we could have an individual that could have been on pressors maybe for 2, 3, 4 days, and their catecholamine reserves are just completely depleted. They are totally stressed out, you would say. When you use ketamine, they're not going to have the reuptake of catecholamine and the blockage of catecholamine reuptake because they simply don't have any endogenous catecholamines. And in those instances, you can see the direct myocardial depressant effect. So that is something important to keep in mind because we can see this patient population in the ICU. And again, things like delirium, hallucinations, and nightmares are common, and that's why we mentioned the benzodiazepines. So let's just talk a little bit about the pharmacokinetics before we dive into some of the specific clinical areas that we can use ketamine. And so norketamine is one of the metabolites. It's about 1/3 as potent as the parent compound, and it does have a longer duration of action, which we'll talk about shortly. It has, it's lipophilic with limited protein binding, and what this means is that it easily crosses into the CNS. Here, we have multiple avenues for drug administration: intramuscular, IV, and intranasal. And so this is attractive for someone that might have, say, agitation, and we don't have IV access. Well, the intramuscular route is an option. And you could see here some of the duration of effects. When you look at, say, an IV form here, that kicks in within 5 to 10 minutes, and it has about a 1 to 2 hour duration. Just keep in mind, this is really dose dependent. And what I mean by that is that since we're going to have metabolism, and that metabolism is going to go into one of the compounds, norketamine, which has a longer duration to be eliminated. When you get into some of the higher dosages of ketamine, some of these numbers could be quite longer. This is a concept that we talk about in anesthesia, which is a context-sensitive half-life, using very high dosages could prolong the elimination half-life. It is hepatically metabolized as well as excreted in the urine. Here you can see great bioavailability for intramuscular and good availability for intranasal and some availability for the oral. Onset of action, really quick for IV, but also onset of action really great, 3 to 4 minutes for intramuscular, again, for someone who doesn't have IV access. And then the half-life for distribution, 10 minutes. The one that we're really interested in, again, is the elimination. But again, keep in mind that there could be some context-sensitive half-life related to the dosages that you might use. So let's jump right into it and talk about certain clinical areas. And the first one we'll start with is acute pain. And so ketamine works on delta, kappa, and mu opioid receptors in addition to NMDA inhibition. It can reduce morphine use with equal pain relief. And this is, again, attractive because with some higher dosages of opioids, we get apnea, and we're concerned about those side effects. And so we can think about working in some low-dose ketamine as an option. Some side effects include dizziness, fatigue, nausea, feelings of unreality, and feeling what's called emotional. What I want individuals to keep in mind is that when they use ketamine, ketamine's going to block NMDA receptors, but magnesium does that as well. And so by using, say, if you're going to use ketamine in a single dose, by concomitantly using it with magnesium, say 1 to 2 grams IV, you can augment the dose of ketamine. In essence, ketamine becomes 2 times stronger with the use of 1 or 2 grams of magnesium. So it's something to keep in mind if you wanted to use a lower dose of ketamine to prevent some of the side effects. This is an excellent option in acute pain management. So specifically, what are you looking at in terms of dosages? Well, for a single shot dose, you can use 0.1 to 0.35 milligrams per kilogram. Just to materialize that for you in an 80 kilogram man, this would be about 8 to 28 milligrams. And then again, given the half-life in the neighborhood of 2 to 3 hours or so, you can repeat this more often, but we generally say maybe approximately every 4 hours or so. But again, if you wanted to do every 2 hours, that could be an option too. Or you can use a low-dose continuous infusion. And here that would be 0.05 to 0.5 milligrams per kilogram per hour. Again, in our 80 kilogram man, this would be 4 to 40 milligrams per hour. So what about an adjuvant to mechanical ventilation? So again, this is very attractive for something to have someone have tolerance to CPAP and BiPAP, as well as maybe high flow nasal cannula, in that it's not going to decrease, for the most part, it's not going to decrease someone's airway reflexes, and it's not going to induce apnea. Keep in mind, hypersalivation could be an issue, but there are multiple ways to deal with that, including maybe using something like glycopyrrolate, which I didn't mention in prior slides. It's attractive, again, in that it will not depress the hemodynamics for the most part, keeping in mind the direct myocardial depressant effects in certain patient populations. It can reduce opioid requirements. It will reduce propofol requirements, further reducing hypotension in our ICU patient population. Will reduce pressor requirements, especially in the short term and possibly long term. However, you could get some tachycardia, and so we'll keep that in mind. But we can see in our ICU patient population, this medication profile here is very attractive to us to work in as an option, and arguably should be used more often because of this. So specifically, what are we looking at in terms of dosages? Well, for single shot dosages, we can do 0.1 to 0.5 milligrams per kilogram. So in our 80 kilogram man, that could be dosages from 8 to 40 milligrams. And again, it can repeat it approximately every 4 hours. Again, you can use it a little more frequently if needed in certain patient populations, or you can do your continuous infusion, 0.1 to 1.5. So when we get to the 1.5, we start to get to quite high dosages. So in our 80 kilogram man, this would be 4 to 120 milligrams per hour. So what about status asthmaticus? This is an excellent agent to keep in mind. Those of us in the OR that have had severe bronchospasm, we're familiar with this because anesthesiologists use this, quite frequently. But I don't I have not had the same experience with this being used as frequently, say, with our ED colleagues or in the ICU. So it's a potent bronchodilator in severe asthma, and that's why we can use it. And most studies have shown lower oxygen requirements with the obviation of the need for mechanical ventilation. And this is wonderful because, as critical care doctors, one of our primary objectives is to prevent as many people as possible from having to go on mechanical ventilation. So this is really an excellent tool to keep in mind. Then in mechanically ventilated patients for severe bronchospasm, if it is used, you show reduction in peak inspiratory pressures, improved gas exchange, dynamic compliance, and minute ventilation improvement, and patients can be weaned successfully off of mechanical ventilation faster with ketamine. However, note high doses possibly are needed in non-intubated patients, may make the risk of dysphoria higher than the benefits if measures are not taken to minimize the dysphoria. So this is that phenomenon again, that if we're using higher dosages of ketamine to break bronchospasm here, then we do have to be worried about the negative hallucinations. But again, we can just pre-treat or treat after we give the ketamine with Versed to prevent someone from recalling. So what dosages we'll be looking at? Well, these are larger dosages here. We can use something small, anywhere from 0.1 milligrams all the way up to 2 milligrams per kilogram. So in our 80 kilogram gentleman, that would be a dose of 160. On the basis of initial response, the dose for continuous infusion can range, anywhere from 0.5 milligrams per kilogram per hour all the way up to 2.5 milligrams per kilogram per hour, which again is a larger dose. And the duration of infusions for the studies that looked at this range anywhere from 1 to 5 hours. So really what you're using it as is to break that acute episode of status asthmaticus, and then looking to wean off of it rather quickly. So what about alcohol withdrawal syndrome? So as more time goes on in the ICU, we're starting to use ketamine more for alcohol withdrawal syndrome, as well as other non-benzodiazepine approaches, such as use of gabapentin and otherwise. So what do we find? So in chronic alcoholics, they experience a downregulation in GABA receptors and an upregulation in NMDA receptors. And so that's one of the things that makes this, very attractive here, is that ketamine is going to be an NMDA receptor antagonist. And it's really some of the upregulation of NMDA receptors in this in the chronic alcoholic patients that lead to their delirium tremens and their hallucinations. So the overall goal here is to prevent seizures and to prevent or minimize delirium tremens. And ketamine it exhibits a mechanism of action similar to alcohol by blocking, again, the NMDA receptor. So what studies have found is significant reductions in ICU length of stay by up to almost 3 days, which is huge, and reduced likelihood for intubation, and reduce total benzodiazepine dose in those centers that still use benzodiazepine as their primary approach in alcohol withdrawal. However, this is interesting to note that emergence reactions were not noted in these patients. So they're not likely to get those negative hallucination effects, and that's likely because they have an upregulation of NMDA receptors. So when would you use alcohol withdrawal here? So if you have delirium tremens at diagnosis, ketamine can be initiated at 0.15 to 0.3 milligrams per kilogram per hour. So in our 80 kilogram patient, we'd be looking at a 12 to 24 milligram per hour infusion, or you can do symptom-triggered ketamine use with your benzodiazepines. And so when they trigger on their CWAS scale, you can give a bolus dose of ketamine, 0.3 milligrams per kilogram. That comes out to, in an 80 kilogram individual, a 24 milligram bolus. So status epilepticus, this is a very interesting use for ketamine and underutilized. So why should we consider ketamine more often in this patient population? Well, there is reduced response to common first-line drugs due to altered GABA A receptor and augmentation of P-glycoprotein-mediated exportation of phenytonin and phenobarbital. And this could be seen rather rapidly in 30 minutes of seizure onset. So what this means is, is that people develop an almost immediate tachyphylaxis to the phenytonin and phenobarbital. So if you rely on these medications up front and the individual does not respond to it, they become, in essence, recalcitrant to it because of this mechanism. So this, coupled with increased exocyticity due to upregulation of NMDA receptors at the synaptic membrane, makes ketamine itself as a very attractive option. Because again, agents such as phenytonin and phenobarbital will not address the upregulation of NMDA receptors, which could be an important component here in an individual status epilepticus. So because of that very quick tachyphylaxis, arguably you want to look to this agent early. The paper here quoted below supports this. So what are dosages here? So a median infusion rate, you can run at 2.75 milligrams per kilogram per hour, plus or minus bolus doses as needed. Again, start ketamine early for what we talked about, that resistance that can develop very early in this recalcitrant status epilepticus. So last topic, just to briefly talk about, is acute agitation. So recall that ketamine has excellent intramuscular availability. So someone who doesn't have IV access, this is a great option to consider. And what we found here in prospective observational study that compared ketamine to a benzodiazepine or haloperidol in 98 patients found that those who received ketamine were less agitated at 5, 10, and 15 minutes. And so those of us that see acute agitation quite frequently in the ICU and just kind of reflexively turn to Haldol or another antipsychotic or a benzodiazepine, which remember could worsen our agitation, especially in the elderly population because of its anticholinergic effects, this is an option that should be thought of more often. So for dosages, we're looking at 3 to 5 milligrams per kilogram. Remember this, the intramuscular method of administration doesn't have as much bioavailability, and so therefore we're using higher dosages. However, if you do have IV access, you can use up to 2 milligrams per kilogram IV bolus. Or you can do continuous infusions, say somewhere between 0.25 and 0.5 milligrams per kilogram IV bolus, followed by a 1 to 2 milligram per kilogram IV continuous infusion. So we did go over quite a lot of dosages. And so if you just wanted one slide that you can print out right here and then post, if you wanted your pharmacy to help you with dosages for all these various clinical syndromes that you can use ketamine, this is an excellent reference right here. Thanks for watching.
Thank you so much for watching and learning with us today. If you're interested in taking this class for credit, or if you're interested in our other services, such as our direct clinical care services, please visit our website at www.med-specialist.net or click on the link in the description below. Also, make sure you subscribe to our channel to stay up to date on our most current content and educational opportunities.